right, so I'm going to get started. So I'm going to go over today the auditory system and vestibular system. So has anybody used Picmonic before? Has anybody heard of that? It's like a study tool. So I know a lot of people don't like mnemonics, but I'm a visual learner, so I just try to throw in different ways that people like to learn. So Picmonic was made by med students. It's a website, and they use like pictures and mnemonics, and they put them together. So I'm going to start off with one of their Picmonics. Hopefully it works. So it might be kind of silly to some people, but again, I think anything that helps you memorize anything is helpful. So let me just play it for you guys. It's only a minute long, so don't worry.
Remember the auditory system like an ear sound system listening to the history of sound. He first hears the sounds of the outer space ear, which represents the outer ear. Then traveling deeper into the ear, he finds the Middle Ages ear, which symbolizes the middle ear. Following the middle ear is the inner ear, shown as the inner city ear playing the sounds and musics of today. However, in the deepest part of the inner ear, we discover the cochlea, represented as the cochlea. Inside of her ear is the organ of Corti, shown as the organ corgi playing her favorite song. Inside the organ of Corti is the inner hair ears, which sit on top of the basilar membrane, illustrated as the hair cells tickling the base salar with membrane drum. So in review, the auditory system is made up of the outer ear, the middle ear, and the inner ear. The cochlea sits inside the inner ear and consists of the organ of Corti, inner hair cells, and the basilar membrane. Sounds good.
Okay, so class is done, right? Everyone knows the auditory system? Yeah. So that just shows you the parts of the ear in a different kind of way, but we'll go through all the parts right now. Let me use this. How do you click on this? Sorry, guys. Oh, there it goes. Okay, so we'll start with the outer ear, the pinna. So this is where the pinna catches the sound waves. It amplifies sound a little bit, and then it funnels it down to the, the tympanic membrane. So what's important to know on this slide is the tragus. So can I use a pointer here? So can you guys see the arrow? Okay, sorry. So what's important to know with the tragus is it's Greek for tragos, which means the like tuft of the goat's hair. So it actually points backwards. So the front of the tragus is pointing backwards. So this helps like distinguish sounds that are coming from behind you. So instead of it being muffled, it hits the tragus and it sends it down the auditory canal to the auditory system so you could hear it properly. So instead of hearing muffled sounds from the back, the tragus helps you hear them clearly. Another function of the tragus is for your earbuds. A lot of people use like AirPods and things like that. If you didn't have a tragus, you wouldn't be able to put those in your ear. So that would be kind of odd. Another use of the tragus is to plug your ears. A lot of little kids just put their fingers in their ears. You could use just the flap just to cover your ears to like stop loud sounds. And has anybody heard that people pierce that sometimes for migraines? Does anybody have that here? And I want to know if it actually really works. So that maybe because you don't have migraines because it works. No. But yeah, so supposedly it works because when you get acupuncture, that's where they would put the needle for to relieve the migraines. Does it work? Like, does anybody have it? Like, if you press there, does it help relieve? Okay, I'm just going to go through some of the parts of the auditory canal. So the ossicles, the malleus, incus, stapes, tympanic membrane, the sebaceous and Sermon glands, and the external auditory canal has the two parts of the bony part and the cartilaginous part. So what I would like you to know on this slide, is the Sermon glands. So I don't know if most of you know, but I was actually in family practice a couple years before teaching here. And if you go into family practice, you'll see a lot of people who have ceraminosis or impacted earwax. You'll see it more than you probably want to see it. Your ears actually clean themselves on their own, so you essentially should never have to clean your ears. But a lot of people use Q-tips and they go in too deep into their external auditory canal, so they keep pushing in the cerumen, and it ends up getting impacted. And so then they're not able to hear. And so the way you solve that, like when you're in the office, you can either tell them to get eardrops, and it's called Cerumenex. Just have them put eardrops in, and after like 3 to 5 days, it loosens up. Or you do like an ear lavage, which you kind of squirt water in their ear. You want to make sure that the water is warm, because if you squirt cold water into someone's ear, they will not be happy with you. So just make sure it's warm water. And otoscope, I'm assuming you would go through this in your clinical skills lab, but have you done it already, or? Oh, okay. So then you guys know that you need to pull the ear upward and outward. I can. Yes, I will. Someone will tell me how to do it, but I will send it to you guys. And so when you're looking through the otoscope, what are you looking at? The tympanic membrane. All right, so you guys could just yell out the answers. I'm not going to call anyone specifically. So what structure is attached to the center of the tympanic membrane? So right there. Anybody?
Head of the malleus?
So it is actually the handle of the malleus. So I'll go in a couple slides, I'll go through where each part is attached. But for this purpose, the answer is handle of the malleus. And here's some, I'm not sure if you guys can see this clearly, but here's some of the abnormalities that you'll see if you see abnormal tympanic membranes. Did anybody see anything abnormal when you guys did this in class by any chance, of if you have perforation or any kind of redness or anything? When it's kind of, I don't want to say fun is the right word, but when you're practicing and you see things that are abnormal, it's fun to see, because like when you hear like bronchi and lungs, or if you see an abnormal tympanic membrane, it's really interesting to see. So is anybody swimmers in here? Oh, go ahead.
Sorry, I just want to confirm, are you going to be posting this PowerPoint at the conclusion of class?
Yes, I will post it. Someone will tell me how to post it. I will give this to everyone.
Thank you so much.
No problem. Sorry, I probably should have gave this as your pre-read and not the actual pre-read. But so is anybody swimmers in here that has ever had otitis externa? Or, I mean, okay, if you're swimmers, not and you've had otitis externa, but if people have experienced it, you don't have to like have it. But so it's usually just caused when after some people swim, sometimes the water doesn't drain out of their ears and it just gets stuck in there. Your auditory canal is a perfect place for fungus and for just bacteria to grow. It's really warm. So sometimes when the water doesn't drain, people get swimmer's ear or otitis externa. And it's usually just clears up on its own. Sometimes we'll give prescription eardrops. And usually the person just complains of redness, there's warmth and some pain, no fever. So for otitis media, acute otitis media, this is an infection or swelling behind the eardrum. And this is either bacteria or virus. This usually clears up in a couple weeks on its own, but if it doesn't clear up after 2 weeks, you should probably see a doctor and see if there's other causes that's causing the prolonged infection.
Dr. DeLeon, I'm
Yes.
sorry, I'm sorry if I missed this, but can you tell, how do we distinguish between the handle of the?
Yep, I'll do that in
head.
like a couple slides coming up. And then where was I? Let's see. So I did otitis media, otitis interna. So that's the inner ear. So what symptoms do you think someone would have? I don't have it on the slide, but we'll talk about the inner ear more. But what symptoms do you think someone would have if they have otitis interna or an inflammation of the inner ear? So the inner ear is where the vestibular system is. So they usually have like dizziness, like vertigo, things like that. So, all right. Let's see. Oh, I got another one on this slide. So do you see this light reflex on here? It's also called a cone of light. So this is important to know. You can tell whether or not you're looking at a picture if that's the left ear or the right ear. Does anybody know how to distinguish that? No, probably not. So obviously, when you're looking at a patient, you're going to know if you're looking at their right ear or left ear. But if you're looking at an exam question or you see this picture, you could tell that it's the left ear because the light reflex is at 7 o'clock. And if it's in the, did I say that backwards? Oh, no, that's right. 7 o'clock is the left ear and 5 o'clock is the right ear. So it's like you're looking at a clock. The 5 o'clock is on the right side, 7 o'clock is on the left side. So of course, what ear is this that we're looking at? Left ear. Thank you. Okay, moving on to the middle ear. So it's an air-filled cavity that sits between the tympanic membrane and the inner ear. It has the ossicles, the round window, oval window, and the eustachian tube or the auditory tube. So here's, I was gonna describe why it was the handle of the malleus. So the head of the malleus attaches to the incus, the body of the incus. And then the long process of the incus articulates to the head of the stapes. And then the foot plate of the stapes sits on the oval window. So I guess if I can go back really quick. So again, so this would be the handle of the malleus because the head of the malleus attaches to the body of the incus. Is that okay with everybody? All right. Okay, so moving on to the middle ear. So this would be a really good picture to know and memorize. Perhaps if I was a test question, I might be somewhere out here. But so we'll talk about the stapedius, the tensor tympani, facial nerve, chorda tympani, and the tympanic membrane. So what's important to know here is that the stapedius is the smallest muscle in your body. It works together with the tensor tympani. It's kind of like a blink reflex. So when you get dirt in your eyes, you automatically blink. When you hear really loud sounds, the stapedius and tensor tympani work together to reduce the sound that goes into your inner ear. You could actually voluntarily tense or contract the tensor tympani. You guys can try it right now if you would like, but you don't have to. But so how you would tense it. So some people could wiggle their ears. Can anybody wiggle their ears in class? Oh, see how that's pretty cool. So you could, like you could really could I see it from here if you guys do it? Like, is it really? So people can contract their tensor tympani. It usually happens when you cough or you laugh or you yawn. But the way, if you want to try it, people can actually do this too to drown out voices. So if you're an expert at contracting your tensor tympani, you could probably do it right now and not hear me. But so what you would do is actually, you would really scrunch your face, grimace your face, scrunch your nose, really close your eyes really tight, and it's described as a rumbling sound. So if you hear that rumbling, then that's you contracting your tensor tympani muscle. And then also important on this slide to know is that the chorda tympani that comes off of the facial nerve, it travels behind the tympanic membrane. All right, the eustachian tube. Moving on to the eustachian tube. So it runs from the middle ear to the back of the nose and throat. If this tube becomes plugged or infected, it is called eustachian tube dysfunction. So the eustachian tube helps regulate ear pressure, and it also drains the excess fluid from the middle ear. And in children, a lot of kids have like ear infections all the time. And the reason for this is because their tubes are a lot more narrower and it's more horizontal. So it's difficult for them to drain the excess fluid that's in their ears. Does anybody have, as a kid, have a lot of ear infections? And sometimes they have to do surgery to put tubes in so the fluid drains properly. Let's see. Oh, and if somebody has this, it usually clears up in a couple of weeks as well. Some other common causes of eustachian tube dysfunction are into vibrations. So the sound enters your ear. What takes those sound waves and turns them into vibrations? Anybody?
The cochlea.
Anyone agree or disagree?
I'll disagree with that. Are we thinking the tympanic membrane or the ossicles? One or the other. Is a tympanic membrane considered outer ear? I figured it was kind of the border there.
So here you go. So it's actually, so it is the middle ear. So it's the vibrations from the tympanic membrane that set the ossicles in motion. So as the sound waves hit the eardrum, it makes the eardrum move back and forth, which causes the ossicles to move further and amplify the sound. So the cochlea, the organ of Corti is located in the cochlea, and the organ of Corti takes sound vibrations and then produces it into nerve impulses that are sent to the brain. Okay, is that clear? Okay, so I'm going to move on to hearing. So sound travels in waves and is measured in amplitude and frequency. So amplitude is the measurement of how forceful a wave is, and so that's measured in decibels. The louder the sound is, the higher the decibel number will be. And frequency is measured in, it measures the number of sound vibrations in a second, so that's measured in hertz. So a healthy ear can hear a wide range of frequencies. So they could hear as low as 20 hertz to up to 20,000 hertz. And so just the takeaway from this is that decibels measure the loudness of a sound, and hertz measures the frequency of the sound. So again, a regular normal person, a person with normal hearing can hear 20 to 20,000 hertz. So 8,000 hertz can be easily heard with everyone with normal hearing. I'm going to do a little test in class right now, so we'll see how well people can hear in class. So yeah, so 8,000 everyone should be able to hear. 12,000 might be difficult for anyone over 50 to hear, like me. No, I'm just kidding. 15,000 hertz may be difficult for anyone over the age of 40 to hear. And 17,400 hertz is a frequency only teenagers can hear. So I don't know if anybody's heard, but they actually have ringtones that only like high school kids can hear. So they download them and they can hear when they get messages or phone calls, but the teachers can't hear them. So it's actually really interesting to, there's an app for it. I truly believe there's an app for everything, but there really is an app for this. So let's see, So high frequency hearing loss leads to an individual having trouble hearing sounds between 2,000 to 8,000 hertz. This means that they have trouble hearing women's voices or children's voices or the sound of S, H, or F. So again, if you go into family practice, you'll have a lot of elderly couples that come in and the wives will complain that their husbands can't hear them or they can't like he has the TV up so loud or like he can't hear my voice. He never like answers to me. It truly is because you just lose that high frequency hearing as you age. I don't know, or maybe the husband is just ignoring the wife. I'm not sure, but it really is there is a scientific reason to it that you do lose your high pitch hearing. I did have one elderly man tell us because we had asked him. The wife was really upset. She's like, "He never hears me," and the elderly man said, "Well, I don't see the problem. I live in a quiet world." And I was like, "Oh, that must be really nice to live in a quiet world." But so let's see here. So does anybody know the term for age-related hearing loss? The medical diagnosis for it?
Presbycusis.
Yes, presbycusis. Good job. Oh, I thought you were done for the day. Good job, good job, good job. I appreciate it. I appreciate it. Thank you very much for participating. So, I'm sorry. So it's often said that the lower the frequency, you can't really hear it, but you can feel it. So if you go to like a concert or you go to a nightclub and you feel the thumping or that deep beat, that's usually the range of like 100 to 120 hertz. So if you like again, so if you're going to some kind of nightclub or concert, that's around 100 hertz. And the lowest note that a bass singer can sing is around 64 hertz. I did look it up that Mariah Carey can sing around 3,100 hertz. So I think she has a 5-range octave voice. Let's see here. Okay, so here I'm going to test everyone's hearing if you don't mind entertaining me for a second. So I'm going to play something. If you can hear it, raise your hand. And when you can stop hearing it, put your hand down. Okay. So, so that's 8,000 hertz. That's the normal hearing that it looks like everyone has pretty normal hearing in here. I try to turn it off fast because I know it could get pretty loud. Is that pretty high pitched for some people? Like nails on a chalkboard almost? So that was the 12,000 hertz that every people under 50 with normal hearing should be able to hear. Dr. Steve can't hear. So you can't hear it, Dr. Steve? Well, do well. Oh, Brianna, you can't hear it? So it doesn't mean you're over 40 either. Just there might be some damage that has happened to your ears that for some reason you can't hear it. Oh, you guys are so they really? That's impressive. Really? That's pretty impressive. So one of the sources that I read that said, if you can hear this tone, you're either a teenager or you're superhuman. So all of you are superhuman to have your hand up. So I cannot hear that. Is that just as clear and loud to you as? So that was 17,400 hertz. That's a good amount of people. Yeah, man. That's cool. Okay. That's the best part of my lecture, so. What was? Did you have a question or? Are you okay? Okay. Okay, let's see, moving on. So moving on to decibels. So again, decibels measures the loudness of a sound. So whisper is around 30 decibels. Normal conversation is around 60. So if you have any extended or repeated exposure to anything over 85 decibels, that can cause some kind of hearing loss. So above 110, so I'll show you some pictures and give you some examples of exactly where these numbers fall. So above 110, that's the threshold for discomfort. Anything over 130 becomes painful. So how long can you be exposed to the following sounds before damage is likely to occur? So a lawnmower is about 88 decibels. I don't know if anybody has a huge lawn that they mow, but if you mow for more than 4 hours without ear protection, you can cause damage to your ears. So does anybody ride a motorcycle in here? I thought I saw one in the parking lot. So if you ride a motorcycle without ear protection, how long do you think you're able to ride a motorcycle before damage begins to occur? 3 hours? Did you say 30 minutes? 15 minutes. So it's about 30 minutes. So if you live on the other side of town, like on Herndon and 99, and you ride your motorcycle to school, you're probably causing some damage to your ears. If you live in River Park, that's probably about 15, 20 minutes away, so you should be okay. And then for a jet engine, so that's about 140, like it says, over 130 becomes painful. So about how long do you think it takes for damage to occur if you're standing next to a jet engine? Immediately, less than a minute. So again, if you're doing any of these activities, here's just a, oh, go ahead.
If you do the 15 minutes, does it like reset another 30 minutes afterwards? Or?
Yeah, because it's the constant sound that affects like the inner ear hair cells and things like that. So the constant sound of like say like you're at a concert, I think it's on this one. Oh, maybe not on this. Oh yeah, so like a stadium football game, it says like 115 decibels for a minute, you start feeling a little like a decrease in your hearing. And then if it's constant, you're at a football game for 3-4 hours. By the time you leave, you kind of hear muffled sounds. It's not necessarily causing permanent damage, but it's causing some kind of damage. All right. So have you guys done the Rhine test and the Weber test in lab? Okay, I'm not going to go through it then because we'll just skip over that. So the main nerve for hearing is the vestibulocochlear nerve. Let me change over real quick. So the nerve is involved with person's hearing and balance. It has two components, the vestibular nerve, which maintains balance, and the cochlear nerve, which is for hearing. So what would I like you to know here? Okay, so if your cochlear nerve is damaged, that causes sensory neuro hearing loss. So that's usually, that is permanent hearing loss. Have you heard of the cochlear implants that people can get? So when someone gets hearing aids, that doesn't restore your hearing. That just amplifies what the person has left. For a cochlear implant, it can partially restore hearing because what it does is it's implanted into their ear and it bypasses the damaged part of the ear and it goes directly to the auditory nerve. So they're able to restore some of the hearing that the patient may have lost. Let's see. So if the vestibular nerve is damaged, this is usually caused by some kind of virus like the measles or chickenpox. And it'll cause like sudden dizziness, nausea, vomiting, trouble walking. So a lot of the things that deal with the balance and and things like that. Those are the symptoms that you'll feel if there's vestibular nerve damage. And then of course, if there's damage to the whole vestibulocochlear nerve, you'll have problems with your hearing and your balance as well. So the vestibular system, it's a sensory system that's responsible for providing our brain with information about motion, head position, and spatial orientation. It's involved with the motor functions that allows us to keep our balance, stabilize our head and body during movement, and maintain posture. So the inner ear has three main parts: the cochlea, which changes sound waves into nerve signals; the semicircular canals that sense balance and posture to assist in equilibrium; and the vestibule, which is the center part of the bony labyrinth. So this is just a image to show what where the vestibule is located. Vestibule, not vegetable. So here you go. So the otolith organs. So these are really important to know. So they're called the saccule and utricle. These are the organs of balance. So these detect movement. They detect linear movement. So it's detect movement or acceleration of the head in a vertical or horizontal plane. So these detect. So the utricle detects if you're moving forward or backward or sideways. The saccule, the way to remember this is that it moves in a vertical plane. So if you're in like an elevator, this is where the saccule detects your motion, and it doesn't make you dizzy or anything. So that the saccule detects vertical plane movement, such as going up and down in an elevator. So the semicircular canals, these detect rotational acceleration of the head. So again, this image is really good to know the parts of it. So first one is the superior or anterior semicircular duct or canal. The names are interchangeable. The lateral or horizontal semicircular duct, the posterior semicircular duct, the vestibular nerve, the cochlear nerve, and then if you just trace it up, they connect to be the vestibulocochlear nerve. The oval window, which is located at the foot plate of the stapes. So when the foot plate vibrates, the round window will move out of the way and the cochlear fluid will be set in motion. And then just anatomically, just know that the round window is located below the oval window. And this helps relieve pressure at the oval window, and it also helps fluid in the cochlea to move. So I think okay, and this is really good to know too. So you want to know that what each canal does. So the anterior canal, or the anterior duct, superior duct, it detects forward and backward movement, such as nodding yes. So you nod yes, that's your semicircular, that's your anterior semicircular duct. For the lateral semicircular duct, that detects rotation of the head around a vertical axis, so that's nodding no, just like that. And then the posterior or inferior semicircular duct detects when you tilt your head towards your shoulders. So those are very, very great to know. Okay. So I have a question coming up. Which of the following converts movements of the stapes into messages for the brain? Anybody?
Cochlea?
Yes. So there's the explanation. The cochlea is a fluid-filled canal that's involved in transforming the physical movements of the stapes into messages that are transmitted to the brain. All right. So next question. What do semicircular canals located within the labyrinth tell us? So what do semicircular canals tell you? Anybody? So it detects rotational movement. And they're semicircular. So that would be that they tell you that you are turning in a circle. So they're filled with fluid, and when the fluid moves, it tells you that you're moving in a circular motion. The motion of the fluid can tell our brains whether we're nodding our heads up and down or right or left. So what's important to know about this one is, say I just ask someone to spin around in their chair a bunch of times, and then I ask them to stand up immediately and walk in a straight line. What's going to happen? They're gonna wobble. They won't be able to walk in a straight line because their semicircular canals, or the fluid in the semicircular canals, are still moving. But if I had somebody spin around in a circle a bunch of times and I put a piece of tape down the middle and had them walk in a straight line, they would do a much better job of doing it because your visual system actually takes over your vestibular system. And that kind of explains, is anybody a ballerina or a ice skater? That explains how ice skaters and ballerinas don't get dizzy when they turn. A bunch of times they do something called spotting. So they find an object and they just focus on that object when they spin. So once they stop spinning, they're able to just continue with what they're doing. Okay, a patient comes in having repeated colds and infections. Problems in his ear are shown to be due to accumulation of fluid in the middle ear. This is due to a blockage of the, anybody? Just yell it out. Anyone? Eustachian tube, thank you. Thank you, Eustachian tube. Okay, so I'm going to talk about some types of dizziness. So again, when I was in family practice, you get a lot of people coming into your office and they say, I feel dizzy. But dizzy can mean so many different things. Like Eskimos have 100 words for snow. We probably have 100 different words for dizziness. So if I ask you, what does dizzy mean to you? Just someone just say what. If you say you feel dizzy, or think back to the time you felt dizzy. Explain to me what that feeling is without using the word dizzy. Nauseous, lightheadedness. The room is spinning. So when a patient comes into your office and they tell you that they're dizzy, you have to really kind of delve in and ask them what's causing it. It could be cardiac related, it could be even anxiety related. So you have to really figure out and ask the right questions to get down to exactly what it is that is causing their dizziness. But I'll go through 4 types of the most common dizziness. Oops. So the first one is pre-syncope. So syncope is syncope is passing out or fainting. So pre-syncope is the patient feels the impeding loss of consciousness. So they usually will feel this when they go from sitting to standing really quick or lying down to standing. And then their response will be like, oh, you feel dizzy? Explain it to me. Oh, I feel like I'm going to pass out. So that could be something as simple as that they're just dehydrated. Just have them drink some water. They might feel better after that. Or it can be something as serious as some kind of cardiac issue. So if you have somebody tell you, I feel like I'm going to pass out, you should ask a few more questions to see if it's actually cardiac related. That means if they're feeling that way and you think it is cardiac related, it's because there's not enough, the blood isn't getting to the brain as fast as it normally should. So that's why they feel that passing out feeling. The second type of dizziness is disequilibrium. So in this one, they're not able to keep their balance. So they'll say something like, oh, my legs are wobbly, or I feel unsteady. And then this one, for disequilibrium, This could be caused either by something simple like an ear infection that could clear up in a couple of weeks, or it can be some kind of neurological disorder. So again, you just have to ask more questions to see exactly what's causing this. Lightheadedness that someone had said, so they'll explain it something like that. They feel like they're floating, or they feel like their head isn't attached to their body. And then vertigo. So vertigo is the most common one. So this is the one that they feel like the room is spinning or like they're getting off of a merry-go-round. And then, like I said, there is another one. It's called behavioral dizziness. So that one, they can't really explain why they feel dizzy, but they just kind of say like, I have like, they're really anxious, or they have a fear of falling, or feel very guarded or apprehensive. So that has nothing to do with their heart necessarily, has nothing to do with their balance. That's really more of their anxiety that's taking over. So it's really important to, when you take the history of a patient, to really delve into what's really causing their dizziness. Oh, I spelled that completely wrong. Vertigo, don't look at that. So there's two, maybe I had some vertigo going on when I did this. So there's two types of vertigo. Has anybody experienced vertigo or going through it now? Because there's actually a procedure that we can do. But if you've experienced vertigo, it's not fun at all. Like, feeling dizzy is a horrible, horrible feeling. But the two types we're going to talk about, there's one called central vertigo, and the other is peripheral vertigo, and that has a few categories that fall underneath it. So there's something called Meniere's disease, vestibular neuritis, and benign paroxysmal positional vertigo, or BPPV, which is the most common one that people get. Is that what you've had before? So labyrinthitis is actually the inflammation of the vestibulocochlear nerve, and that will cause, like, that would actually fall under, I believe it falls under the peripheral vertigo, just because the central vertigo, I'll go through it. I might have it on my slide coming up. So central vertigo is caused by disease or injury to the central nervous system. So this would be either caused by head injuries or multiple sclerosis, migraines, brain tumors, or strokes. If somebody has central vertigo, this usually comes on without warning, and it lasts for a long period of time. The symptoms are very constant, whereas in peripheral, they come on severe and then they go away eventually within a couple of weeks. Central vertigo could last months to years of someone's life. Do you guys know nystagmus, like the eye movement? So that happens in both types of vertigo, but in central vertigo, if someone has central vertigo and they have nystagmus, sometimes they won't be able, like, let me repeat that. So if someone has peripheral vertigo and you see them have nystagmus and you tell them to focus, they're able to focus and the nystagmus will stop. Whereas if they have central vertigo, you tell them to focus, their eyes will still keep moving. Yeah. Oh, so you had labyrinthitis? I have it. I'll double check for you, because I was reading on that one, but then it went away though. Because if the inflammation goes away, but does it still come? Okay. I'll have to double check on that one, because I believe it's peripheral, but yeah, some of the symptoms sound like central as well. And then some of the symptoms that someone will have with central vertigo is they'll have headaches, weakness, and sometimes they'll have trouble swallowing as well. I'm sure if people have like migraines, they'll have central vertigo, and again, it's not a fun feeling. And so the treatment for central vertigo is you have to treat the underlying condition. So, for example, if somebody had migraines, you would have to treat the migraines. For someone with something like multiple sclerosis that's long-term, you're usually just treating the symptoms because there's really no cure for it. All right, so moving on to the peripheral vertigo some of the categories that fall under peripheral vertigo. So Meniere's disease. Does anybody know that anyone that's had this? This is kind of like almost a lifelong disease that happens. So this is characterized by excess fluid accumulation in the vestibular and semicircular canals, causing increased fluid pressure in the inner ear. So here are some of the symptoms that someone with Meniere's disease will feel. So they'll have tinnitus or the ringing in their ears. Most of the people who have Meniere's disease, they will have one-sided hearing loss. They do report nausea and vomiting, and they'll describe their vertigo as a whirling sensation. And doctors don't know actually what causes this. It usually happens between the ages of 30 and 60, and it just comes on. But nobody knows exactly why this actually happens. So for the treatment, there's a number of treatments that can reduce the severity and the frequency of the symptoms, but again, there's no cure. So yeah, you can give, if your dizziness or causes severe symptoms, there's some medications that you can take. They also say that for some reason they'll also recommend a low salt diet as well, because I'm assuming it's because of the excess fluid built up in the ears, and if they recommend low salt, low caffeine, cutting down on alcohol, and reducing your stress, which will reduce the symptoms if you have Meniere's disease. Yes.
Sorry, I was just curious. I guess you just said a low salt diet. I know my dad was diagnosed with Meniere's disease, and I believe he said that they gave him a diuretic to take, actually. Do you know if that's common practice, or maybe was like a thing that they tried, like made an exception to try with him, or?
No, that's not, that actually sounds like a proper treatment, I guess you can say. Yeah, because there's something about the salt in the diet that causes this to flare up. So that using an antidiuretic actually sounds like a treatment that should be used with someone who, if they don't want to cut down on their salt just intake in general, that would be a perfect treatment to give somebody. Okay, vestibular neuritis. So this involves swelling of the vestibular nerve, and it affects the balance. So generally the symptoms are very severe. They'll have very severe dizziness and vertigo, but it only lasts a couple of days. But while it's present, it makes it difficult to do anything. So this is kind of a little bit probably, I'm sure, what you had. Like, you probably can't even watch TV or go to the bathroom, do anything. Like, it's really uncomfortable if you've ever had any type of vertigo. You definitely don't drive. And then after this symptoms lessen, most people make a normal recovery, or full recovery. It usually takes about 2 to 3 weeks. And this is usually caused by some type of virus like the flu or mononucleosis or shingles. So BPPV, benign paroxysmal positional vertigo. So this is the most common type. It causes sudden spinning sensations, causes brief episodes of mild to intense dizziness, and it's caused by abnormal movement of the otoliths in the semicircular canals, causing vertigo and nystagmus. So the way I like to describe this to patients when they come into the office, there's something called the Epley maneuver. Has anybody heard of that? Okay, so it's a maneuver that you use. It's very benign to do. Again, if your patient comes in and they say they're dizzy, you could easily try the Epley maneuver. And if it doesn't work, then you can do further follow-up with like a cardiologist or a neurologist. But we do this. I did this a lot in my practice. So the way I explain it to patients is that your inner ear is like a snow globe, and it's those crystals kind of get stuck at the bottom. And what you need to do is just do these maneuvers that kind of loosen those crystals up to get them flowing again in your semicircular canals. So yeah, pretty much what it is that those crystals get dislodged and they go into the wrong places. So you want to kind of joggle their heads to get those crystals back into where they actually belong. So the Epley maneuver, this is the best image that I could come up with, but it's, so what you do is you put the person's head, I could demonstrate it to somebody if somebody wants to do it, but it's actually really good to know, like, I was never taught this in medical school, but I will say, like, I did this so many times actually practicing. So it's a really, like I said, it's very benign. You could do it. Even if it doesn't work, at least you tried it, and then you know that it's not a peripheral vertigo that this person has. But so what you do, you just put the person in 3 different positions. You start with the right head, you lay them down, and then you do it 3 times on one side, and then you do the 3 other movements on the other side to do both ears and essentially dislodge the crystals that are in each semicircular canal. So that's why you do it. There's 3 on one side and 3 on the other side. But if anybody ever wants me to show it to them, I'm more than happy to. There's like hundreds of videos online on how to do it. I would highly suggest not doing it yourself if you have it, because there's a chance that you can fall. You're already dizzy and miserable to begin with. So I would either suggest going to a doctor's office or having some sort of professional doing it the first time. And then if you have these episodes multiple times, you'll eventually know how to do it yourself. So here's just a table of the differences of the peripheral vertigo and the central vertigo. Oh. Okay. Oh. I'm almost done. Maybe after this, and I'll do the Epley maneuver so everyone can see it. So here's a question. So table 14, can you read this question for me, please?
A 5-year-old girl ruptured her eardrum when she inserted a pencil into her ear. Her mother took her to the emergency department after noticing that the child was crying and complaining of pain in her ear with a few drops of blood in the external auditory meatus. The attending doctor examined the child for possible injury to a nerve that runs across the eardrum. The most likely nerve to be injured is the...
Anybody can answer. What was that? Yes. So I did go, oh yeah, I did say it earlier. So the chordotympany branch of the facial nerve goes directly over the tympanic membrane. So that's where you want to, if a child inserts a pencil in their ear, they're damaging the tympanic membrane, which will damage the chordotympany nerve. All the other nerves are nowhere near the tympanic membrane. So there's, what happened there? So I think you did learn this in one of the TBLs. So if your chordotympany branch is actually damaged, what can happen?
Loss of taste.
Yes. What part exactly?
Anterior 2/3.
Yes, so if you damage a chordotympany, you will have loss of taste in the anterior 2/3 of your tongue. You'll also have reduced saliva secretion on the affected side. Increased pain, you'll actually have increased pain response in the tongue, and your increased taste perception of salt, or your taste perception of salt will also increase. Usually if someone perforates their tympanic membrane, it usually can heal on its own. They do have something called a tympanoplasty. It's a surgery that they can do that will cover the hole if it doesn't heal on its own. This is the last question. Which of the following portions of the auditory system contains receptor cells responsible for sensory transduction? So which cells are responsible for hearing? That is the organ of Corti. So the organ of Corti contains the inner hair cells, which are the receptor cells that are responsible for hearing and sensory transduction. These cells translate vibrations into electrical impulses that are carried to the brain by the sensory nerves. So if you remember the organ of Corgi and the inner hair cells sit on the basilar membrane. And that is it. And here's a picture of Hay's best friends. One is a Corgi, and one is a Boston Terrier German Shepherd mix. And that is it. So I will, if somebody wants to volunteer, I'll show you how to do the Epley maneuver. Anybody? Oh, no, he's already walking up. I don't know if oh, is there a way to use the camera? Where's Dr. Steed when I need him? Well, you guys want to take a quick break anyway, or not really? Oh, there he is, Dr. Steed. Do you know how to use this camera so they can see what I'm doing? Oh, perfect. Realize I was going to finish.
Did you want it to be pointed on the whiteboard or something?
Where he is sitting. So
Oh.
can we use that camera?
Oh, okay, yeah.
Oh, will they be able to see it on Zoom or no?
No.
Oh, I'm sorry, Zoomers.
Let's see if we can. Yeah, it's not working.
Oh, that's me. So some of you have seen this maneuver, correct? Okay. So the way that I was taught to do it, so you ask the patient, you can sit like that's fine. So you ask the patient which ear is affecting them most. So pick an ear. Right. So your right ear. So what you'll do is you'll have them, actually you'll sit on the edge of the bed. Okay, so turn your head towards me. You can go ahead and cross your arms, and then you just lay back. You want to help them because they're usually dizzy. So you go ahead and drop your head. So turn your head right. So you actually want, I usually use a like a rolled up towel because you want it right under their shoulder blades because you want their head to hang low. So you go like that for about 30 seconds or so. If they feel dizziness, it's actually a good sign because that's when you know they have the BPPV. So it's moving the crystals around. So you do that. If he has no dizziness, what you're going to do is, can I have someone help me go on this? So you're just going to stand here just so they don't fall off the bed. So what I'm going to ask you to do is roll over and look straight down to the floor. Actually, let me have you scoot up a little bit more. Sorry. Because normally you pull out the table. Okay, so the next movement for the other semicircular canal, you'll turn over and look straight to the floor. So just go all the way. So they'll usually, again, like people will tell you, they're like, and you want them to keep their eyes open. That's really important. You want them to keep their eyes open because you want them to almost trigger that dizziness. Okay, so then you do that again for 30 seconds. So the next thing is what you're gonna have them do is I'm gonna have you swing your feet over this and you're gonna sit straight up and look straight at him, okay? So, yep, and then I'll help you up. You're gonna look straight at him. Ready? Now sit up. So swing your legs over. There you go, look straight at him. So this is when you'll notice nystagmus. So you'll see nystagmus if they have dizziness. And then if they do, you just wait till the nystagmus stops and then you do the other side. So you'll do the same thing, but for the other ear. So then you just start, we won't do it again, but you'll just start and you'll do it on the left side. Huh. Did that cause any dizziness? I don't want it to. Okay, good. So, but like I said, that's a really good maneuver to know and do, because if, like I said, if your patient comes in, they tell you they're dizzy, they don't know why, you can try that. And if it works, that's great. It usually actually, I've been told it works up to like 6 months to a year that they won't have the dizziness. And if they do, they can always come back and do it again. And that is it. Oh, yeah.
Okay, I'm going to ask a question and hopefully it's not frowned upon. So when someone drinks a lot and they get the spins, is that because you've affected this system?
You know, I actually did think about that question this morning. I don't think it's necessarily, I mean, I'm sure it plays a part in it, but like I said, like when you're like walking in a straight line, if someone's like gets pulled over for a DUI and they ask them to walk in a straight line, I think that's just more of the alcohol and their, I guess you can say it's their balance, but I don't think it's really necessarily the vestibular system that's impaired necessarily.
Can I comment on that? So I am absolutely not sure if this is true. So please, if this sounds completely ridiculous, please say so. But I heard that particularly when you are hungover, like it has something to do with basically the fluid in your inner ear, that some of the alcohol that you consumed actually filters into that, and because it changes the density of that fluid, that affects your balance.
That would make sense too, because with a Meniere's disease, it does say as well as to cut down on the alcohol. So now that you're saying that, there probably is. I'm going to look it up and find out for sure for you, but there's probably something true to that statement that alcohol does play some sort of some part in the vestibular pathway, that whether it inhibits it, it probably does something of that nature when you drink excessive amount of alcohol. But I'll find out for sure, because I actually did think about that question this morning. I was like, oh, I didn't have time to look it up. Anything else? All right. I think we're done then.
Hello? Hello?
Oh, yes, yes.
Yeah, so I know that this PowerPoint is kind of completely different. Do we have to know both PowerPoints or is it just
No,
the
no.
second one?
I will upload the second one.
But should we study both for the exam? Because they have different like highlights. Or should we-
So in my pre-read, if something is highlighted, that's probably important to know for the final exam. For the practical exam, this PowerPoint will definitely be a lot of help. But I would probably focus more on this one. If you had to choose and you were limited on time, I would focus on this one. All right.
Thank you, Dr. DeLeon.
Thank you.
That was a great lecture.
I got like out of breath. Oops, let me turn this off.